Hello, everyone, and good afternoon. My name is Franklin. I'm one of the two co-founders of NorCal SCI, also known as the Northern California Spinal Cord Injury Foundation. Welcome to tonight's presentation on gastrointestinal issues and considerations for those with SCI. And in case if you're wondering, gastrointestinal is also commonly referred to as GI. Anyhow, we have a very informative and well-researched program that Shelley has prepared for you that'll literally tell you everything that goes on from the sort of original point of entry, which is your mouth, all the way to where the exit is. So looking forward to Shelley sharing that information with us. Okay, as usual, a few things. Everyone has been muted so that we could eliminate any background distractions. And we will have ample time for a robust Q&A session that Shelley is prepared for towards the end of the presentation. And you can use your chat feature on your Zoom screen to feed me any questions throughout the presentation, or as we get closer, I'll remind you that we're getting to that point. As usual, these presentations are made possible thanks to the generosity of NorCal SCI's donors, so we're grateful to them. And finally, we are recording this presentation, and that way anyone that needs to jump off the call or those people that were unable to join us, we will send a recording of this thing. It'll be in your inboxes first thing tomorrow morning, so don't worry about missing out on anything. And so without further ado, let me go ahead and introduce Shelley. She is a lifelong advocate of nutrition. When she isn't working with her patients, she can be found in her greenhouse or kitchen. She obtained her BS degree in nutritional science from my alma mater, San Jose State University, in 2012, her master's in public health in 2016 from the University of New England, and has been working at Santa Clara Valley Medical Center, one of the top spinal cord injury rehabilitation hospitals in the country since 2013. She currently works in the outpatient clinic of the hospital, seeing primarily those with SCI, and also spends time working with complex GI issues in the outpatient gastroenterology clinic. And also, full transparency, she's a member of NorCal SCI's advisory board, which we are thrilled to have. So thank you for joining us again, Shelley. It's all up to you now.
Hi, Franklin. So let me just share my screen. 1 second. Okay, I hope everyone can see this.
Yes.
Good. Okay, so I was just scrolling through everybody, and I see some real familiar faces and names here. So if I know you, it's so nice to see you. It's so nice to see everybody. Quite a handful of people here. I have a lot to share with you. So I took on working in the outpatient GI clinic about a year ago, actually exactly a year ago. I left inpatient, and I'll tell you more about that in a second, but this GI is just, it's mind-boggling how much goes on in your GI system. And I'll tell you more about that in a second, but we have a lot to talk about. I'm going to tell you a lot about the GI system. I'm going to break down a lot of information for you along the way, and I really sincerely hope this is helpful. It's hard to pinpoint one specific thing. I know constipation, I would want to say probably 80% of you are here because of constipation and want to hear about it. So I'm going to share as much as I can about that. But I do encourage you to listen to a lot of my presentations that I've done over the last year, because I talk a lot about constipation. It's very common. Jumping ahead of myself, but we have quite an agenda to talk about. Want to leave some time at the very end for questions. If you have questions, I'm sure you will. But again, when I left inpatient rehab and joined the GI team, I enjoyed my steep second learning curve. The first major learning curve I had in this practice was learning about spinal cord injuries. They just teach you 2 equations in school when you're studying to be a dietitian. So I continue to work with outpatient SCI population, both in outpatient, in the community, but I have found myself working with GI conditions and those with spinal cord injuries constantly. So getting involved with the GI team and working with all the physicians that I work with now that are from VMC and also Stanford has been the best possible marriage between the two fields. It's been fantastic. The GI system's really complex. I rarely meet a patient who's had a spinal cord injury that doesn't have some kind of a GI issue, at least from time to time. This can range from occasional bloating to full-blown fecal impaction. I've seen it all. I've met with spinal cord injury patients, and I have seen each of the conditions I talk about in some way or another. Some are more rare than others. So I'm going to touch briefly on all of them as much as I can. On the multiple GI conditions, I'll share some spinal cord injury research pertaining to the community as much as I have found along the way. I think a basic good understanding of how the GI system works can go a really long way to understanding your symptoms. I myself have gained a healthy respect for the complexity of GI, and I really hope that you enjoy learning some of the basics that I've encountered. And I hope that, again, some of this information is helpful for you. So we're going to go over a general overview of just the function of the GI tract. Food doesn't just go in, make you happy, and then disappear. As much as we would like to think that, it's not true. There's so much there. Little bit about the gut microbiome, which is brand new research. We're really looking into that now, and it plays a huge role in many areas of life. We'll talk about reflux, super common in those with spinal cord injuries, irritable bowel syndrome, all the different kinds of IBS. We'll talk about lactose intolerance, which is pretty common, often misunderstood. Celiac disease, this is pretty rare. I've had probably 2 or 3 patients who've had spinal cord injuries with celiacs. Very interesting. Irritable bowel or inflammatory bowel disease, which is different from irritable bowel syndrome. So there's IBS and there's IBD. The inflammatory bowel disease is a lot more complex. This is the Crohn's and ulcerative colitis. And again, I've had a few patients who've had spinal cord injuries with that as well. Talking about liver disease, just briefly, gastroparesis. We'll chat a little bit about neurogenic bowel. Hopefully you have a little understanding of what level you are and kind of where you're at with that. If not, I'll share what I know, and then you can get the rest from your physiatrist or your doctor. Of course, we're going to cover constipation. This is the hot topic, and diarrhea as well. I'm going to do a little bit of a fiber breakdown, more of a review. I talk about fiber a lot, and I will always talk about fiber. I also threw in some slides on colostomy. So if you have a colostomy, or if you're thinking about a colostomy, I'll share some of the nutrition information that I have on that. And hopefully that will leave enough time for many questions, which I anticipate we will have. So let's chat about the GI system. This is just the quick Cliff Notes version. I don't know if you know what Cliff Notes are, but it's going to be quick. So just hang in there. We're going to start with the mouth. Okay, so the GI system is huge. It starts with the mouth, and as Franklin said earlier, totally stole my thunder, Franklin. It goes from the mouth to the anus. The GI system digests, and is where we digest and absorb our food. It provides a barrier, both physical and immune, and much more. It's broken down as the upper GI, which includes the mouth, the esophagus, that long tube, the stomach, the duodenum, which is part of the small intestine, the lower GI tract, which is the jejunum and the ileum, which are both parts of the small intestine, the colon, which is also known as the large intestine, rectum, and anus. That's pretty much it from mouth to the anus. And then you have some accessory organs. Think of it like your purses, your accessories that help with digestion. So the salivary glands are accessory organ, the liver, the pancreas, and the gallbladder. Those are your accessories that you have in your GI system. There's multiple phases of digestion. Starts with the mouth, the oral phase. This is where your teeth break down your food. Those salivary glands make and release saliva, moisten the food. There's an enzyme that's made that's in your mouth called amylase. This is where your carbohydrates and your starchy foods start to break down in the mouth. So you have an enzyme in there already breaking down your bread and your pasta and your rice, those things. The tongue starts the pharyngeal phase of swallowing. The tongue is what initiates everything. Then you have the swallowing phase. So you've done all this in your mouth, and then you have the swallowing phase, and there's 3 phases. The oral phase of swallowing, where the food and the saliva mix. the pharyngeal phase where food moves to the back and the respiratory tract closes so you don't inhale the food, hopefully, and the esophageal phase where the food moves down in these waves all the way down that long tube, the esophagus, and it's passed into the stomach. So now the food's in the stomach. Now what? Now we have the stomach and the gastric phase, same thing, stomach, gastric. The stomach's normally the size of a clenched fist. A lot happens in the stomach. So you have gastric acids, you have hormones, you have digestive enzymes. All of this works in the stomach to break down the foods that came down there. And when that's done, it's passed into the small intestine, where most of the digestion and absorption of that food is done. So the small intestine is kind of the workhorse in GI. Everything gets through the stomach and broken down, but this is kind of where the hard work starts, in the small intestine. This is the largest part of your system. It's 20 feet long. 20 feet, that's a lot of feet. Think of a football field. It's like a big chunk of a football field there, and it's just your small intestine. A lot of work's done here before the nutrients can be transported into the bloodstream and sent into the liver. The 3 parts of the small intestine, like I mentioned, and you don't have to memorize this, I'm not going to quiz you, I promise, but the 3 parts of that 20-foot small intestine are the duodenum. Now that's where the carbs, proteins, and fats are broken down into smaller pieces and where fat absorption's mainly done. Then you have the jejunum, where most absorption of nutrients is done. And the last one, the 3rd one, is the ileum. This is where vitamins, electrolytes, and other nutrients that were passed through the jejunum are absorbed. So now we're done with the small intestine. We go to the large intestine, which is that drapey thing that's kind of bigger that drapes up across and down. The large intestine's about 5 feet long, and it has 2 main functions. One is to absorb water and electrolytes from the leftover material that passed through the small intestine, and to compress it down, the rest of the material, so it can be removed. This material will hang out in the rectum until it leaves the body, basically just chilling in there. Now you have your purses, your accessory organs, the pancreas. So the pancreas works by regulating blood glucose levels, by making insulin, making digestive juices for breaking things down and neutralizing. Now remember, there's acid in the stomach, so the pancreas is key here. It releases bicarbonate, which helps bring that acid down. Otherwise, you're going to burn your intestines. So the pancreas is really responsible for neutralizing that acid in the stomach. And then the liver, that's another accessory organ, but it's the largest gland in the body, and it makes and secretes bile, which is needed to break down the fat in your diet. And then you have the little gallbladder where the bile is stored. That literally is your purse. That's like your bile purse, and that's where the bile is stored. When the gallbladder is removed, the liver takes over completely. The liver becomes your Prada bag or whatever. Like, it does the rest, it does the job, it takes over. It takes a little time, but it adapts. GI system is fantastic. Oh my gosh, I'm starting to sound like Steve, the crocodile guy right now. I'm so excited. I love the GI. Anyways, so now let's talk about the gut microbiota. This is kind of new science. We've been looking at the gut microbiome for years, but it's really starting to become something that we're learning more about as technology increases. The human gut microbiome includes about 10 times more cells in it than there are in the entire human body. It plays a huge role in our overall health, metabolism, immune system, development, even our human behavior. There's so much going on there that we just don't know and understand yet, but we are studying it. It is made up of thousands of species of bacteria, viruses, fungi, protozoa. It varies from person to person and populations. It shifts to some degree over time. Changes are driven by diet, lifestyle, environmental exposures like method of birth, social contact, hygiene, cleanliness. Those are all things that affect your gut microbiota. Genetics play a key driver. There is no one-size-fits-all approach to diet when it comes to this, because everybody's microbiome is totally different. The person next to you has a completely different universe inside of them than you do. As far as looking at the gut microbiome and those with spinal cord injuries, recent investigations all conclude that there are changes in the gut after an injury, but the science is really new. Future studies are going to be looking at how signals between the central nervous system gut axis influence long-term outcomes with regards to the gut microbiome. But right now, there's no known interventional strategy specifically for people with spinal cord injuries above what we're trying to understand already in the able-bodied population. So stay tuned. I fully anticipate that we're going to have more information on this for the spinal cord community in the future. It's definitely something that is being looked at right now. And as soon as I hear something about it, I'll let you know. But right now, what we know for a healthy microbiome is important diversity of whole foods. So that means abundant fruits, veggies, beans, raw veggies, all that stuff, plant-based. You can call veggies and beans also prebiotics. They help feed the bacteria in your gut and keep it healthy. Also, fermented foods like yogurt, kimchi, sauerkraut, kefir, tempeh, those are all fermented. Eat a plant-based diet. So if you know me and if you've ever watched any of my presentations or even Arash's presentations, then you know I'm huge on a plant-based diet. Also, new moms breastfeeding, if at all possible, will play a huge role in your baby's microbiome as well. So that is what I have right now for the gut microbiome. Again, plants and fermented foods and that kind of thing will help. All right, so now we're going to kind of go into some conditions, common conditions, things that I run across all the time. Heartburn, okay, gastroesophageal reflux disease, otherwise known as GERD. Very common in not just the able-bodied, but also in my patients with spinal cord injuries. Very common, called heartburn. It is common. It's often referred to as heartburn. 20% of US adults actually have reflux. 20%, that's a lot. It happens when the pressure from the lower esophageal sphincter. Now you can see that is right above the stomach. So you can see the stomach there at the bottom of this picture, and there's a sphincter right above it that allows food into the stomach. You want it to go in there. It's a sphincter, it's a one-way valve. So what happens is the pressure that from the lower esophageal sphincter relaxes, and it's not supposed to relax, but it does, and it lets contents from the stomach, mostly acid that's in the stomach, into the esophagus, that tube going upward, which damages the lining. So again, consider the sphincter a one-way valve for the contents of the stomach. Symptoms for this might be like an acid taste in your mouth, burning sensation. Oftentimes you'll feel a burning sensation right in the middle of your abdomen, right underneath the ribs, right in the middle. Burping a lot, regurgitation of food, things coming up, burning, that burning in your throat, dry cough, lots and lots of dry coughing, which is a kind of a reaction. What can you do? So one thing you can do, lifestyle tips, wear loose fitting clothes if you're not already. Anything that's tight around the waist is probably not a good idea. So if you're not wearing loose clothing, do that. Don't smoke. Smoking actually relaxes the sphincter, that valve. It relaxes it, so that is a problem. There's a handful of my patients who smoke, and I hope that they're not on here. If they are, stop smoking. Raise the head of your bed. That's another really big one, and it really helps. Raising the head of the bed 6 to 9 inches. So a foam wedge between the upper part of the top mattress, like between the bottom and the top, or like if you have a hospital bed, raise the head of your bed up 6 to 9 inches. If you don't have a hospital bed, no way to prop up the top mattress, then propping up the legs at the top of the bed with wooden blocks. Stacking pillows doesn't work. It's not effective. But be aware. So also be aware that if you do raise the head of your bed and you're sleeping like that you may put some pressure or shearing on your sacrum. So work with a physical therapist, occupational therapist, your doctor, someone figuring out how to do that to where that doesn't put pressure on your sacrum, because I don't want you to fix your heartburn by elevating the head of your bed and feeling better, but then getting a pressure ulcer. So please You're gonna have to figure out something between the two. Here's another one. This is common. Wait at least 3 hours after eating before you lay down. So we do use, even though we have those waves that I talked about, pushing the food down your esophagus, you need gravity too. It really helps to help bring that food down into your stomach. You want that food to get into the stomach, broken down and moved into the small intestine. After about 3 hours or so, you should be okay. It should be gone, and you should be okay to lay down. So eat several small meals throughout the day. So eating smaller meals makes sense because you're just digesting, you're passing down small bits of food through your stomach. They should get into your small intestine quicker than if you have a Thanksgiving dinner. So eating several small meals throughout the day can help. Staying calm, eating relaxed, eating slowly. Stress can make reflux worse. So stay calm and relaxed. Certain foods kind of make this worse. And I have a lot of patients who have made changes to their diet that have felt so much better. I know many of my patients with spinal cord injuries are also on Protonics or Nexium, omeprazole, pantoprazole. Like all of those are helpful, but diet is really helpful too. Along with them, the two together can really make a big difference if you have reflux. So common foods that can actually make symptoms worse: peppermint and spearmint, chocolate, alcohol, caffeinated beverages, that's a big one, coffee, regular tea, Coke, energy drinks, even decaf coffee and decaf tea. Let's see, I said peppermint and spearmint. Pepper, spicy food, that's a big one, spicy foods. Also a word about high protein diets. So when you eat a lot of protein, there's an enzyme in your stomach called gastrin, which helps you break down the protein. But that enzyme also increases the acid to break down the protein, which can worsen symptoms because you have more acid going on there. So that can really make reflux worse. Another thing is super high fat foods, foods like whole milk, cream, high fat cheese, high fat yogurt, bacon, all the fun foods, right? Fried foods, fried meat, sausage, pepperoni. I don't need to go through the whole list, but any kind of high fat or fried food can make symptoms much worse. Sometimes fruits and vegetables, certain fruits and vegetables, it really depends from person to person, but common ones like oranges, orange juice, tomatoes, tomato juice, those kinds of things. Acidic foods, they can really irritate the esophagus too. So that is reflux, and reflux is common and it is not fun. So hopefully some of that information gives you an idea of maybe what you could do to help. So irritable bowel syndrome, IBS, this is a disorder characterized by altered bowel movements and abdominal pain. This affects 10 to 15% of the US population. It's more commonly diagnosed in women, and IBS results in poor quality of life. It has adverse economic impact because of missed work days, healthcare costs, and it's measured in billions of dollars annually. It's very complex, and it has chronic symptoms like constipation, diarrhea, abdominal pain, discomfort, bloating, flatulence. But the diagnosis is key here. It includes symptoms that have gone on for at least 6 months and are classified in 3 ways. So it's important to remember IBS is something that's been going on for a really long time. So nothing that ebbs and flows. This is constant symptoms for 6 months or longer. And the 3 classifications are IBS-C, which is primarily constipation, IBS-D, which is primarily diarrhea, and IBS-M, which is a mix of both, like fluctuating constipation and diarrhea. Many symptoms for IBS actually mimic the symptoms for celiac disease, which I discuss in a second here. So if you've had these symptoms for a long time, they should screen you for celiacs as well, both of them. Triggers for IBS flares can include stress, infection, antibiotics, aspirin, surgery. The most common thing to provoke IBS symptoms, though, food. So a gold standard diet, once you've been diagnosed with IBS, is called a low FODMAP diet. This is a super complicated diet, something that you need to work on with a dietitian and a GI team, but Just so you know, if you've been diagnosed with IBS, then the gold standard diet would be this low FODMAP diet. Basically, FODMAPs are parts of food that are poorly absorbed and they're highly fermentable to the gut bacteria, which create a lot of uncomfortable symptoms. Most common FODMAPs are lactose, which I'll talk about, from dairy, fructose, like certain fruits like apples, pears, and also honey, fructans like wheat, rye, garlic, onion, and soy, and what's called polyols, avocado, sugar alcohol, mushrooms. Basically, the bottom line for this information is if you've had the symptoms for a long time, like over 6 months, and you've had abdominal discomfort, pain, and bloating, and those symptoms improve with your bowel movements, then get a referral to a GI team and a dietitian would be my suggestion. IBS symptoms can be reduced significantly with dietary changes, but supervision is really needed for just to kind of figure out what in your diet. I have a lot of patients with IBS in the GI clinic, a lot of patients. And I've gone through this low FODMAP process. It's an elimination diet. And I have found there is no two people that are the same with IBS. I have one patient that's violently sick with garlic, and then the other one is mostly lactose. So it's like really, it's a kind of a detective work to figure out what in the diet is contributing to it. And it certainly is not a fun process, but let me tell you, my garlic patient and my other patients, they know exactly what they need to avoid. So lactose. So lactose intolerance is more common than you think. Between 65 and 70% of the world's population is lactose intolerant. And I'm telling you, 65 to 70%. It's more common in some parts of the world than others, like Africa and Asia. Can be diagnosed early on or much later in life. Even if you drank milk for your whole entire life and you're 60 years old, you may realize you're lactose intolerant. It just comes on sometimes. Oftentimes it's just overlooked until it's pointed out. Lactose is found in dairy products like milk, yogurt, ice cream, cheese, sour cream, and other dairy products. Lactose is a kind of sugar that's digested in the small intestine by an enzyme called lactase that your body is supposed to produce to help break it down, lactase. People that have lactose intolerance, they're not able to fully digest the lactose because they have too little of the enzyme lactase in their small intestine. And because of this, those with lactose intolerance have varying degrees of diarrhea, abdominal cramping, pain, bloating, gas every time they eat dairy. And the treatment, obviously, avoid all dairy, or now you can buy dairy with the enzyme lactase already in it, like Lactaid milk that has lactase inside the milk, so you can just drink it. Or you can buy the lactase enzyme pill and keep it with you wherever you go. The key to this is if you use the lactase enzyme pills that are over the counter, you have to take it with your first bite of dairy. Whenever you eat dairy, it has to go in with your first bite. You can't take it an hour later or an hour before. Take it, because what it does is it breaks down the lactose for you at like when you start to eat that food. So, and a lot of people don't know that. So hopefully I was able to help at least one person today. Okay, so celiac, briefly, this is pretty rare. Like I said, I've only had a couple of patients with celiacs, but celiacs, for your own curiosity, it's an autoimmune disorder where your immune system basically attacks your body. In the case of celiacs, eating foods with gluten triggers an immune response that causes inflammation and damage to the small intestine. So the picture on the bottom left is a normal lining, the wall of the small intestine. Those are villi, they're called villi. And the picture on the right is a damaged one. So as you can see, there's definitely something going on there in the small intestine. You want to have the villi on the left. You don't want to have them removed or broken down, damaged. You don't want any of that. So basically, what is gluten? Gluten's a general name for proteins found in wheat, rye, barley, and triticale. Triticale is a hybrid grain made from wheat and rye. Those who have celiacs can have no symptoms, and it can be completely, they don't even know they have it, but the most common symptoms when they pop up are abdominal pain, diarrhea, weight loss, and blood in the stool. Diagnosis includes blood tests. They do an upper endoscopy, and then they do a biopsy of the small intestine. With a diagnosis of celiacs, the diet is just complete elimination of gluten for life. But thankfully, there are many other options to substitute. There's corn, oats, quinoa, rice. There's a bunch of other ones. And because the gluten-free craze in the recent years, it's a lot easier to be gluten-free than ever. I do cringe when I hear people are not eating gluten, but they don't have a celiac diagnosis or there's varying degrees of gluten intolerance, but it's best to get an actual formal diagnosis rather than just cutting out gluten out of your life. There's many processed foods that have hidden gluten. So if you are gluten intolerant or you have celiacs, you'll have to be a diligent label reader, become a really good ingredient reader, or just follow a plant-based diet and eat as natural as possible, because whole foods don't have labels. And broccoli, is gluten-free, right? So it's a lot easier to eat gluten-free if you're eating like that. This diagnosis requires close following, again, same as IBS, by a GI team and a dietitian as well. Most people with celiacs can live a relatively symptom-free life with the diet. Okay, so another one, inflammatory bowel disease. This is different. Inflammatory bowel disease, IBD, is not to be confused with IBS or irritable bowel syndrome. It's a debilitating condition that is characterized by chronic intestinal inflammation. So there's two kinds of IBD. The most common types are Crohn's disease and ulcerative colitis. So there's about 3 million Americans that have IBD diagnoses. It's most commonly diagnosed between the ages of 15 and 30. Basically, ulcerative colitis is inflammation affecting only the mucosal lining of the colon and the rectum, and it can involve all or part of the large intestine. Symptoms would be like diarrhea, abdominal pain, and blood in the stool. If you're having blood in your stool, then you definitely need to get a consultation from GI, okay? Because some of the serious conditions that I'm talking about, hallmark symptoms are blood in the stool. So that, and I'm not talking about hemorrhoid blood in the stool, that's different. So this one here, this requires a special diet. Risk factors could include family history, smoking, and stress. Interestingly, though, those of Jewish heritage are also at a higher risk for IBD. There was a 2009 study looking at family clustering of Crohn's disease in Israel, but other factors might include aspirin, oral contraceptives, antibiotics, and so IBD is an actual diagnosis. Okay. I'm going to speed up slightly. For the liver disease, the common one here is non-alcoholic fatty liver disease. So there's a lot of fatty liver out there in the world, mostly in America. Honestly, 4.5 million Americans are diagnosed with liver disease in 2018. The most common one is fatty liver. Risk factors for fatty liver is obesity, metabolic syndrome. And metabolic syndrome, in case you're wondering what that is, it is a cluster of conditions that occur together to increase risk of heart disease, stroke, and diabetes. Metabolic syndrome includes increased blood pressure, high blood sugar, excess body fat around the waist, and high cholesterol and triglyceride levels. Up to a third of adults have metabolic syndrome. And basically, what I can say is diet is very, very important if you have these things. So severe liver damage can lead to cirrhosis. This happens later on. And so it's very important to, if you get diagnosed with fatty liver, talk to a dietitian. It's important to overhaul your diet. If you're overweight, it's important to lose weight. Sugar and salt are pretty important to look at. Dropping the salt down is probably one of the most important things you can do if you have a diagnosis like that. Okay, so gastroparesis. This is more common in those with diabetes and uncontrolled blood sugar over a long period of time. This can affect people who've had certain surgeries around the esophagus, the stomach, the small intestine, certain cancer treatments. Basically, though, uncontrolled blood sugar can lead to nerve damage. the vagus nerve, which can impact motility, like basically how fast food empties out of your GI system. Symptoms might include nausea, vomiting of partially undigested food, heartburn, feeling really full after eating only a little bit, loss of appetite, weight loss, bloating, reflux, stomach spasms. Basically, if you're diabetic, what can you do if you're having gastroparesis? Control your blood sugar. So that is the most important thing that you can do. Diet things you can do: small frequent meals, avoiding high fat and greasy foods because those are really hard to digest, and high fat foods move really slowly through your body. High fiber foods, avoiding those things, they move slow as well. Avoid eating foods that increase reflux, like acidic, spicy. We talked about that already. So another thing that I can point out also with gastroparesis, but also really helpful for many GI issues, if you're having bloating and just distension, not feeling well, mostly bloating, carbonated beverages can increase that. Chewing foods really well before swallowing and eating slower, that's really helpful. Making sure that you stay upright, again, with gravity. Don't lay down for hours after eating if possible, that kind of thing. So hopefully that's helpful. This, again, I don't see a lot of gastroparesis in my patients without diabetes. Okay, I want to get to the meat and the potatoes of this. I know you're waiting for the constipation probably and the other slides, but neurogenic bowel. So I'm still learning about neurogenic bowel. It's fascinating, but it's very complex. It's basically the loss of normal bowel function, and it's caused by a nerve problem. A spinal cord injury may damage the nerves that help to control the lower part of your colon. It can cause constipation and bowel accidents because of the interference with bowel control. There are several main kinds of neurogenic bowel depending on the nerves that were affected. Again, I mentioned earlier, your doctor can tell you if you're upper or lower neurogenic bowel, and then this can help you with managing your symptoms, usually with bowel medications and then diet, of course. So I'm going to go over some fiber information and things that might help with upper versus lower in just a minute here. But what I'm trying to say with this slide is it's helpful to know if you're upper or lower neurogenic bowel, if you have neurogenic bowel, because that can help drive some of your nutrition choices, and it can also help further your discussion with your team and figure out if there's any ways that you can improve your bowel program. This is a very important slide here. So you don't have to memorize this slide, but think Bristol stool chart. If you're having issues, GI issues, bowel issues, constipation, diarrhea, any kind of bowel issue, remember the Bristol stool chart, because if you're able to bring this up to your team, say to your physiatrist, to a dietitian you're working with, any of your clinicians, like even your physical therapy, if you can tell them where you are on this chart regularly, then that's really helpful, actually. So basically, this is a chart of poop. So type 1, basically means you're constipated, and type 2 as well. So I won't go through all of this, but the Bristol stool chart's really important, and you're going to blow their mind when you say, hey, I'm consistently a type 2 on the Bristol stool chart. That's really going to give your doctor some important information for your treatment. Okay. Constipation. Okay. So constipation is loosely defined as having 3 or fewer bowel movements per week. Less frequent bowel movements is associated with lower abdominal discomfort, distension, bloating. It is a common complaint in those who've had spinal cord injuries, and it can be quite a problem, especially in higher levels of injury where autonomic dysreflexia is present. Bowel programs can be much more effective with changes to diet. So diet is sometimes overlooked, not thought of as closely as it should be, specifically with an increase of fiber and fluid. Many of the patients that I work with are chronically dehydrated to start with. And increasing fluid intake has improved constipation in so many of my patients, but it is something that's overlooked. If you have an intermittent catheterization program, though, and autonomic dysreflexia, no chugging your water. Don't chug your water. You're going to need to talk to your doctor, make sure how much water you can safely drink between cathing. Otherwise, it can cause a problem. As for fiber, this should be increased slowly over the course of a few weeks. So constipation is water, make sure you're hydrated, and fiber. Those two things play a huge role. Generally, food is ideal over fiber supplementation. A wide variety of food with fiber in it seems to be a little more tolerated, better tolerated than straight fiber supplements. So if you can alter your fiber intake with your diet, that would be ideal. So the most common gastrointestinal comorbidities, comorbidities is the presence of 2 or more medical conditions, involve colorectal function. There was a study that found that 40% of people with a spinal cord injury experience constipation. 40%, that's a lot of people. Spinal cord injuries change how the intestines work. They change the transit time of food, making it longer to get from all the way through. Changes the amount of fluid absorbed, which can make the matter drier stool, which increases constipation. It worsens symptoms. Incontinence or unplanned bowel movements or accidents often goes along with constipation. Constipation with incontinence means that the food is probably not moving smoothly through your GI tract. Incontinence occurs when fluid leaks around the stool that's stuck or moving slowly. Having a bowel accident doesn't mean that you've solved your constipation issue. Incontinence also seems to get worse with age. Having more frequent bowel programs might be the answer, and I often hear this working in the outpatient clinic. Increasing your bowel program a little bit might be the answer to your constipation. Doing it regularly is very, very important, never skipping your bowel program. Another complication pertaining to spinal cord injury is fecal impaction, and symptoms for that include loss of appetite and nausea. Another thing I want to point out that you should think about, if you're feeling nauseous and you've had constipation, many patients are given anti-nausea medications like Zofran, and that can actually make constipation worse. Just so that you know, talk to your doctor about if you're on anti-nausea medications and you're struggling with constipation. Oftentimes the two counteract, and it can make it worse. Tips, okay, so this is important for constipation. Slowly increase the amount of fiber that you eat over the span of a few days. You should increase your fiber by no more than 5 grams, I would say every couple days until you reach about 25 to 35 grams a day. If you increase your fiber super fast, it's going to make you really uncomfortable. Basically, whole grain breads and cereals, 100% wheat, bran as the first, whole wheat, oats, bran, first or second ingredient, brown or wild rice instead of white rice, a variety of grains. I have a whole bunch of tips here and things that you can do, but the ones that I think are the most effective for my patients that I work with, flax and chia seed can be really helpful. Prunes and prune juice have a laxative effect. Let's see, calcium and iron supplements can make constipation worse. So think about calcium and iron supplements if you're on them. There's some new research on kiwis, and I've had a couple patients try that. Kiwis, depending on the time of the year, they can be a little expensive, but if they're on sale or if you can get them for reasonable, there was some studies down in New Zealand, go figure. They actually had a bunch of patients eating a couple of kiwis a day, and that improved their constipation. So they're really looking at kiwis right now. So another thing that I want to point out, look at the fiber content on your nutrition facts label. Look at the serving size and how much, just determine how much you're going to eat of that food, and then look at how many grams of fiber are on there. And if you're buying some whole grain crackers, take a look at the fiber per serving and try to get the highest one. That's how you increase your fiber when you're doing that. Otherwise, again, the easiest way you can increase your fiber is to eat abundant fruits, vegetables, and whole grains. Those are all full of different fibers. Okay, so diarrhea. Contrary to what you might have heard, if you're struggling with diarrhea, less fiber is actually better initially. Fiber basically bulks up stool, it pulls in water, and it makes things move a little faster. So you want to be really careful with certain kinds of fiber. You want to limit foods and beverages that have sugar, lactose, fructose, high fructose corn syrup, sorbitol, prunes and prune juice. So some of these things may be beneficial for constipation, but not for diarrhea. Juice in general is not very good for diarrhea. Gatorade is not helpful at all because of its sugar. Pedialyte, if you're looking for electrolytes and you want to get electrolytes in if you've had diarrhea pretty bad, then Pedialyte's a much better option. Antibiotics, it's common to get diarrhea if you've been on antibiotics. And so I recommend, if you're not lactose intolerant, to get unsweetened yogurt and eat that for a while after that, or a probiotic supplement. Avoid caffeine if you have diarrhea. Sometimes eating a small snack or a meal every few hours can be helpful. Spicy food can make matters much worse if you have it. And then if you're just dealing with like antibiotic type diarrhea, like temporary diarrhea, then you can think of the BRAT diet: banana, rice, applesauce, and toast. Specifically white rice and white toast, but banana, rice, applesauce, and toast, those are helpful when you have diarrhea. So fiber here, a word about fiber. There's two different kinds of fiber. There's soluble fiber, which attracts water and turns to gel during digestion. This actually slows things down a little bit, makes it easier to pass. And then insoluble fiber. This adds bulk to stool and helps it pass more quickly through the stomach and intestines. It speeds things up. Think of soluble like a blobby gel. Think of insoluble fiber like a kind of a Brillo pad, cleaning things out. Both of them are really important for good bowel health. And you can, if you eat a huge mix of fruits and vegetables and whole grains, then you're getting both soluble and insoluble fiber. You can use them to speed up and slow down bowel movements if you need to. But specifically for neurogenic bowel, a mix of soluble and insoluble for upper neurogenic is helpful. So all the fruits and vegetables, all the whole grains, upper neurogenic. If you're dealing with lower neurogenic, which you might end up with more incontinence and loose bowel movements, diarrhea, more on the soluble side. So that's just what I have found over years of practice. Make sure you're getting enough water. Again, water is really important. Whether you have constipation or diarrhea, it's really important. Okay, I'm going to go through colostomy considerations kind of quickly because I want to get to questions. That was a lot of information. Colostomy, kind of where the large intestine or the colon's removed or bypassed. Remaining part of the functioning colon's brought through the abdominal wall. It creates a stoma, and it can be temporary or permanent. Right after you get this done, your things are going to be harder to digest. Your bowel is going to be swollen. You want to stay with low fiber. Don't go high fiber for a little while. You'll probably start on a clear liquid diet, lactose free if you have lactose intolerance. You need to chew your foods really, really well after you get a colostomy, even down the line when you have one. But as you go, you can start adding higher fiber foods after about 6 weeks. But the thing to know is you can manipulate your output with your diet. So these foods can cause blockage, which you don't want. Be aware of these, especially in the early stage right after you get your colostomy. You may want to go back to this presentation. And actually what you can do, these lists are super helpful. You can reach out to Franklin, and I actually have some information on colostomy diet I can share with you. So reach out to Franklin and I'll get that over to you. But there's certain foods that can cause blockage. There's certain foods that can cause gas or odor. Remember, you have a pouch. So there's foods that can cause gas and odor. There's foods that can actually relieve gas and odor. There's foods that can discolor your stool and scare you, like beets. Beets can scare anybody. It doesn't matter if you have a colostomy. colostomy foods that can make output more loose or more frequent. Say it's getting too thick and you want to thin it out a little bit, you can eat some of these foods and that'll thin it out. There's foods that can thicken your stool, and say it's too watery and you want your output to be thinner, you can thicken it up a little bit with peanut butter and bananas. And that's pretty much it. That was a lot of information that I threw at you. It was a lot of important information. So if you need clarification on any of these specific conditions, I'm totally fine if you reach out to Franklin, and I'll get back to you on it. But wanted to touch on as much as I possibly could in this short amount of time we have. Franklin. I can't hear you.
All right. The good thing that we have going is we've been recording this presentation, because I know, and Shelly and I had talked about it, this is a lot of stuff. The whole GI system, as you saw, is a complicated and complex sort of piece of machinery, and especially once it gets impacted by a spinal cord injury. So as I mentioned, you're all going to get a copy of this recording first thing tomorrow morning, and watch it again. And if you have any questions, send them my way. And Shelly is always wonderful about taking on questions. So speaking of questions, Shelly, surprise, surprise, we have a bunch of questions.
Okay.
Okay, first one, are digestive enzyme supplements safe to take?
Okay, I'm going to say the same thing about supplements as I always say. Number one, make sure you get your supplements from like a reputable place. Make sure you don't buy them at the dollar store. Make sure you take your supplement, your digestive enzymes. So these are fine. These are generally pretty safe.
What do they do? What is their function, Shelly? Maybe you can explain to her.
Digestive enzymes. So basically, all the enzymes I talked about in digestion, amylase and lipase, like all of the enzymes that help you break down your food, they have them in supplement form to help you digest foods. Whether they're as effective as the human enzyme, we don't know, probably not. But for some people, they tend to help. So go ahead and bring your enzyme to your doctor. The main thing I want to say about any supplement questions that are asked today is I want you to take them to your doctor and make sure there's no medication interaction potentially with them. Because a lot of my patients with spinal cord injuries are on a lot of medications, and supplements beyond vitamin D or vitamin A or like the vitamins should be definitely scrutinized by your doctor and made sure that they don't interact with your medications.
And in large part because they're not regulated, right? So
they are not regulated very well by the Food and Drug Administration. There have been studies that have found that the ingredients in certain supplements are not what they're saying are in there. They've gone and they've tested them, and they have found other things like lead in them, and they come from other parts of the world. So the purity of these supplements are questionable, and they're not regulated very well at all. So they can actually be quite dangerous.
Okay. All right. This next question, and I know how you're going to answer it. The question is, do you recommend a vegan or vegetarian diet for SCI individuals? I eat mostly fish, seafood, and chicken, and I'm reluctant to give those up as long as I'm healthy.
Okay. So my thing, you're laughing. Okay. My thing is, I'd say 90% vegetarian. If you can get 90% plant-based, and okay, you can become a vegetarian and you can eat like donuts, you know? So no, what I mean is plants. So if 90% of your diet is fruits, vegetables, whole grains, heck yeah, eat some fish, eat some good quality fish, and once in a while chicken. If you like beef, you've got 10% to play with right there. So I'd go as high as you can with plant-based foods, like actual whole foods, and then you have your like area of play there.
Yeah. And by the way, everyone, as Shelly mentioned earlier, she's a huge proponent of plant-based diet. And if you go to our website under the video section, you can really go back to a number of sessions that she's done, as well as with Arash in terms of cooking and preparation of really plant-based foods. Just familiarize yourself. You'll be surprised how tasty this food can be
Mhm.
And you might be able to give up some of those fish or chicken, maybe a little bit more of them than you have been.
And I want to say back in July of last year is where it started, the overview of a healthy diet. And then I broke it all down by protein, carbohydrate, fruits, vegetables, fats. I broke it all down. So it's really helpful. And yeah, plant-based is preferred. And I've come to this over my work of 8 years with spinal cord injuries. And the science is very crystal clear on this.
Okay, very good. By the way, I will be working on a plant-based donut. That's going to be, you have any, I'll be a millionaire, right?
You know what? All I can think of right now is slicing a peach into the shape of a donut. There is no such thing as a plant-based means like a plant.
Right.
Unless you can find a donut growing on a tree, then you'll have
Yeah,
a
right,
problem
sure.
there.
Okay, moving on to the next question. So this person spends, because of his condition involving blood pressure, he spends an more than usual amount of time in bed, and as a consequence, he tends to eat more in bed. You mentioned that try not to sort of lay down after eating for 3 hours at least. Any suggestions for people that don't have a whole lot of choices in that matter?
Okay. I've got patients that have had flap surgeries and they're flat, and that's all they can do. Take a look at the slide that had reflux and that kind of thing. If you're struggling with reflux by laying down, remember there's certain foods that can increase your reflux symptoms. So just remember high fat, greasy foods, acidic foods. Go back if you want to. I have a really good handout on reflux. In fact, just email Franklin. I have a really good handout on reflux with a whole list of foods recommended, list of foods not recommended, and I can share that if that's what you're talking about. I'm not sure if you're talking about reflux there, but
okay,
I'm
all
assuming
right.
so.
Yeah, hard to tell. Okay, next question. Is it safe to take 3 to 4 Senna tablets per day?
Okay, that's a doctor
Next
question right
question.
there.
All right.
Definitely.
Okay.
Sorry.
Next question. Cleansers, I guess that's what she's referring to, or he's referring to. From all juice cleansers to supplement cleanse, I have heard they work or they don't work. What is your opinion regarding cleansers? Do they work? If so, is there an all-natural one that works?
Okay, so assuming you're talking about like maybe the lemon juice cleanse with cayenne pepper, something like that. Okay, so you have some organs in your body, the kidneys and the liver. Those are the organs that are responsible for cleaning out impurities, taking toxicities out of your body. Unless you have kidney disease or liver disease, you don't need to cleanse at all. Like your liver and your kidneys, they will handle that for you. I think the best possible thing you can do is fill your body with fruits, vegetables, and whole grains. Eat mostly plant-based. That is absolutely the most ideal way to treat your body, especially if you are like at risk for heart disease or any other comorbidities. Then you probably want to just do that rather than just suffer like doing a cleanse. Yeah.
Okay. Alrighty. Next question again about Senna. Is Senna necessary to take? Maybe you can talk about what
Okay,
sort of
so bowel
application.
programs. It's very important to establish a bowel program with a physiatrist, someone hopefully that has experience in spinal cord injury. They are going to help set you up with your bowel program. And with that, you want to have an ideal diet. So you need to do the two things together. And I can't say this enough. I have a lot of patients who come to me that just like, I've been doing my bowel program, not getting results. Things are not working for me, but their diet is complete crap. So you have to address the two pieces, the diet, the medication part. And sometimes because of neurogenic bowel, you are going to need Senna, you might need Miralax, you might need Digestem, you might need multiple modalities of bowel program plus diet. So definitely want to ask about whether you need medications or not. You might not be getting enough fiber. I mean, if you're not drinking enough water, you're not eating enough fiber, maybe that's why you have all these bowel medications. If you improve your diet, then who's to say, maybe you might end up like reducing or eliminating some of it.
Okay, very good. Next question. How do I know if it's time to get a colostomy?
Okay, another medical question. This is a quality of life question. So, and caregiver question. It depends on your level of injury. It depends on, your other medical diagnoses, that kind of thing. That's a conversation you should really have with your team. Hopefully, again, you have a doctor who has experience with spinal cord injuries, or you can talk to somebody, a physiatrist, someone like my mentor, Dr. Shem, that knows all about spinal cord injuries, that can tell you if you'd be an ideal candidate. If I've heard this before in rehab, if you're a para and you can do a bowel program, you can transfer yourself, then I would say probably not, but you just need to confirm that with your doctor and your team. But I've seen a lot of patients improve their quality of life where otherwise they wouldn't have when they got one.
Yeah,
So.
okay. How would a doctor diagnose IBS? Are there lab tests that help as indicators?
There are, and then they take a look at your symptoms and over how long they've been going on. So they would probably do a colonoscopy, maybe an EGD, and do some blood work, and that's how they generally diagnose that.
Okay, alrighty. We had someone that asked if they can get a list of foods to eat or avoid if they have a colostomy. I'm more than happy, everyone, to send that slide to you. But again, if you watch the video, Shelley, you can just sort of pause it.
I have more information. There was so much information for colostomy that I just couldn't share. So I'll just go ahead and make a note real quick right now while I'm thinking about it. I'm going to email that to you, and I don't know how you'll share it, but we'll figure it out.
Okay, very good. Okay, this next question, I'm trying to understand what the intent is. The person is asking about blending fruit and veggies.
Okay.
She says something about she likes using NutriBullets.
Okay, so I know what that is. I have one. So it's basically a high-powered personal size blender, pretty much. Blending food is okay once in a while. I mean, the thing about a NutriBullet or a Vitamix, it blends the whole thing. It's not a juicer. You don't throw anything. That's fine. But remember when we were talking about the GI system, how a lot of the action for digestion starts in your mouth with chewing, and like it initiates a lot of activity down below when you start to chew your food. So if all you're doing is blending and drinking your food, you're not getting the digestive benefit from actually eating it. That being said, it's okay to make yourself a little smoothie here and there with the NutriBullet or any blender once in a while, but definitely want to try to balance it out by actually eating foods as well, chewing them.
Okay. Very good. This next question, again, might be a doctor question. The person is asking if a 3-day interval for bowel program is unhealthy. He switched because there's less trauma to ditch them than a 1 or 2 day interval. Any thoughts on that?
That is another good question for a doctor, but 3 days seems like a long time for me. And I read all the doctor's notes that my team writes. I don't skim them, I read the recommendations, and 3 days seems like a really long time. I don't know what kind of results you're having, if you're constipated, if you have incontinence, diarrhea. I think I see more success with more frequent bowel programs. So that is definitely a talk that I would have with the doctor, but 3 days seems like a lot to me from what I've heard.
Okay. All right. Again, I know how you're going to answer this one. The gentleman is asking thoughts on keto diet with SCI, or keto diet.
Keto. Okay,
keto.
So pull up my protein presentation. I am not an advocate for a keto diet. I've seen some pretty negative cardiovascular.
Can you explain what it is, Shelley,
okay,
real quick?
Keto is super low carb diet. It's under 20 grams of carbs per day, basically initiating what's called ketosis, where your body burns fat for fuel. It's very low in fiber, practically no fiber at all. So a lot of the patients that come to me who have been trying a keto diet usually for weight loss, end up with severe constipation and high cholesterol and all kinds of things. And this is over the long term too. So I don't recommend a keto diet. If you're dealing with diabetes, if that's one of the reasons why you've gone that low in carbohydrates, you can definitely have some carbohydrates. You don't have to go keto though. You can eat less carbs, but you definitely need carbohydrates. Your brain functions really good on carbs too. So.
Okay, all right. I think one last question. It's about IBS or celiac. Is it more prevalent after experiencing a spinal cord injury in your experience?
No, you know what? The couple of patients that I've had with celiacs actually came to me. They had that before their injury, so it's not something that I've seen ever happen because of an injury. No, definitely not. It's definitely something that was there beforehand or diagnosed just kind of concurrently.
Okay. All right. One last question got snuck in. What is it? Why do the intestines sort of process the food slower post SCI?
I think it has to do with the central nervous system. That's a really complicated, wow, mind blown here. It has to do with transit and your nervous system and the disruption in the pathway, the signals. I did see something recently, research on it, but it was one of those things where I think I needed a pot of coffee to read through it. But they're definitely seeing motility issues with people who've had spinal cord injuries and things moving a little bit slower, less efficiently. It is definitely a problem. So.
All right, good. Okay.
Yeah.
So everyone, again, Shelley is a registered dietitian nutritionist. She would be acting unethically if she attempts to answer sort of questions that should really be directed by a physician. And I know, we all want to know the answers at sessions like this, but she's really, barred from making, attempts at answering questions that are really beyond her scope of expertise. So as difficult as it might be, please, engage your physician about, questions that Shelley has already identified. Okay, I see that someone snuck in one more question. They just started taking the magnesium powder.
I put a lot of info in and I didn't leave enough time at the end. So that's my fault.
No worries. Okay, so this person is saying that they started taking a magnesium powder called Calm, and I've noticed a big improvement going from 1 to 3 on the poop scale. Didn't know that such a thing existed.
The Bristol stool chart. No, I follow.
Are you familiar with it? And does having fewer bowel movements put you at higher risk for colon cancer?
Having fewer bowel movements, constipation. Sure, that's why we get colonoscopies, right? And they're not fun. I mean, I haven't had one, but whatever. Magnesium. So that is something that I've heard can help with bowel movements.
Isn't that kind of the base
it's
ingredient? Yeah, don't they use that for like colonoscopy? Some
magnesium citrate, you're thinking. And okay. Yeah, some laxatives and things like that have it. But magnesium also kind of like relaxes you too. It is safe, but again, like with magnesium, it's a mineral. And so I think it's important to make sure that your doctor knows you're taking magnesium too, in case there's some potential interaction again with a medication that you're taking. But I know a lot of patients who take Calm, which has magnesium, and it helps. I wouldn't use that like as a bowel program type thing, but clear it by your doctor to make sure it's okay. But generally magnesium is safe, and deficiencies in magnesium are really rare. So I would just say you're just adding extra magnesium to your diet.
And what would be the plant-based version of magnesium? What kind of food?
I think beans have a decent amount of magnesium. You can also just Google like foods that have a lot of magnesium in them, but I want to say beans. Plants in general have anything that grows out of the ground. Think of it this way, like we have a lot of minerals in the ground, sodium even in the ground, magnesium, all of those things grow in the ground. So anytime that you're eating foods that grow out of the ground, you're getting those minerals. Okay. That's the easiest way to think of it.
Very good. Okay, that's all the questions we have. Thank you everyone for tuning in tonight. As I mentioned, we have been recording this thing, and you will have the copy of the recording first thing tomorrow morning. And I'll work with Shelley on sort of any additional sort of collateral that we could include in the email that you'll receive tomorrow. And once again, thanks to our donors for making events like this possible. Thanks for tuning in. Again, hope you enjoyed it, and have a good evening. Thanks again, Shelley.
Bye. Nice to see everyone.
All right. Good night, everyone.